Toxoplasma gondii and opportunistic protozoa. Toxoplasma is an obligate intracellular coccidian parasite. It gets the name from a small rodent in North Africa, in the body of whom Nicole and Magnox in 1908 found the Toxoplasma parasite. So it is worldwide in distribution, is most commonly found in Middle East, Sri Lanka, USA and Australia, and nearly about 30 to 40% of most countries are seropositive, and the incidence is higher in France and Scandinavian countries. So this is a coccidian parasite with a sexual sporogenic phase and an asexual schizogenic phase, and it is spread over 200 host species of birds, reptiles and mammals including man. There are three morphological forms. In that there are two asexual forms, that is trophozoite or tachyzoite and tissue cyst, and one sexual form, that is the oocyst, which is involved in gametogony or sporogony. So these are the trophozoites. So as you can see, it has a anterior end which is tapering and a posterior end which is broad. It's also called as tachyzoid because it is the rapidly multiplying form of the parasite. It stains with gympsa, and these are the internal structures of the trophozoite. It infects all mammalian nucleated cells. So once it infects or gets into the host, it forms a parasitophorous vacuole and start dividing inside it by internal budding. The host cell starts to distend by the multiplying trophozoites and appears as a pseudocyst. Coming to the next form, that is tissue cyst. It is the resting stage of the parasite. So the parasite starts multiplying within the host cell and produces round to oval tissue cyst, which is inside which we can see crescent shaped multiplying trophozoites called as bradyzoites. They are called bradyzoites because it is the resting stage. So these are the bradyzoites. It is eosinophilic in nature and stains with silver and pus. Coming to the sexual form, that is the oocyst. So this is found in the definitive host, that is cats. Unsporulated oocyst is excreted in the cat's feces, which is non-infectious. It later undergoes sporulation, forming two sporocysts containing 4 elongated sporozoites. So these are the two sporocysts inside which we can see 4 elongated sporozoites. That is, this is unsporulated oocyst, this is the sporulated oocyst. Coming to the life cycle. Two hosts are involved. One is definitive host, which is nothing but cat, in which sexual cycle takes place. Intermediate host are the human beings, pigs or sheep or rodents, in which asexual cycle takes place. Coming to the asexual or exoenteric cycle. So all three morphological forms are infective in case of Toxoplasma gondii. So tissue cyst which is found in the infected animals, it could be sheep or pig or a rodent. So consumption of these infected animals causes infection by in the form of tissue cyst. So tissue cyst gets released into the infected person or the infected animal. Okay. Second one is sporulated oocyst. So sporulated oocyst gets excreted from the cat, and this could contaminate the food and the water. So the person who consumes the contaminated food and water gets infected from this oocyst, from which the bradyzoites could be released or the sporozoites could be released. The third form is tachyzoid. So these tachyzoids get into the body of the infected person through blood transfusion, organ transplantation, or a needle stick injury. Okay, so by any of these modalities, tachyzoids could enter into the human body. So thus all three forms are infective in case of Toxoplasma gondii. Now once any of these forms gets into the body, what happens? They get transformed into tachyzoids. The sporozoites are released and they invade the intestine. Okay. Now from in the intestine, they spread to the extraintestinal. They first go to the mesenteric lymph nodes and then they spread to the extraintestinal sites like the brain, skeletal muscle, cardiac muscle, eye, liver, etc., where they transform into bradyzoids. They form the tissue cysts in all these organs. Okay, so that is the asexual cycle. Now what is the sexual or enteric cycle? So the ingestion of tissue cyst in the meat of rodents causes the initiation of the sexual cycle. The bradyzoites are released from the tissue cyst and they undergo several cycles of schizogony. So after several cycles of schizogony, gametogony begins, wherein the male and the female gametocytes are formed, which get converted into male and female gametes. Then fertilization occurs, zygote is formed, then the unsporulated oocyst is formed, which is released in the cat species. So after 1 to 5 days, that transforms into sporulated oocyst. Okay. So here the cat is consuming the tissue cysts from which is present in these rodents or the birds, and inside the body of the cat gametogony takes place and the oocysts are formed. These oocysts could be consumed either by the animals or could be consumed by man. Okay, and also man could be infected from the contaminated blood transfusion. Okay, and also the infected mother could transmit the infection to the baby through placenta. That is the main pathogenicity of Toxoplasma gondii, infection of the baby which is in the infected mother. So congenitally or transplacentally from the mother to baby, infection can get transmitted. Okay. Now coming to the pathogenicity. Risk of fetal infection is about 25% in the first trimester and 65% in the third trimester. But the severity is higher in the early trimester, though the incidence is less. But if at all it occurs, it can cause a severe infection in the baby. Okay, and in case of immunocompetent patients, uh, both humoral and cellular immune responses control the infection, and toxoplasmosis is usually asymptomatic, okay, and self-limited in case of immunocompetent patients. There could be only lymphadenopathy and mild fever. Okay, but in immunocompromised patients, we can see that usually in immunocompromised there could be a severe type of infection where the structures like skeletal muscle, myocardium, retina, placenta, CNS, all these organs could be infected. Okay. Now coming to again to the congenital infection, what are the features of how does a mother get infected? A fetus may contract toxoplasmosis through placenta. How the mother gets infected? It could be by improper handling of the cat litter. So cat litter contains the oocysts. The infected cat will be releasing the oocyst, and if the pregnant lady deals with these infected cat litter and without washing hands she consumes the food, so she can get infected with the oocyst, and thus the baby could get infected through placenta. Now what are the features of congenital toxoplasmosis? There could be cerebral calcification leading to convulsions, bilateral healed chorioretinal scars, hydrocephalus, microcephaly, organomegaly, rashes and fever. Then acute toxoplasmosis also has the same features, more so of the eye manifestations, cataract, glaucoma, chorioretinitis, and also there could be cerebral calcification and myocarditis. Acquired toxoplasmosis or the toxoplasmosis in asymptomatic patients, as I discussed in immunocompetent patients as discussed earlier, it's usually mild lymphadenopathy and flu. But sometimes there could be exanthema, myocarditis, pneumonitis and meningoencephalitis. Ocular toxoplasmosis can occur in patients who are immunocompromised. Toxoplasmosis in HIV patients targets mainly brain. There could be toxoplasma encephalitis, and they can also have ocular toxoplasmosis. Now coming to the lab diagnosis. So the samples which should be collected for the diagnosis are peripheral blood, body fluids, lymph node aspirate, bone marrow aspirate, CSF, and bronchoalveolar lavage for HIV infected patients. Coming to the lab diagnosis, so mainly first is microscopy. So microscopy could be done on any of these samples. We can see tachyzoites or trophozoites and tissue cysts which could be stained by GIMSA, PAS, GMS, Gomery's methenamine silver stain. And direct fluorescent antibody technique can also be done wherein tachyzoites can be detected, okay, by using fluorescein conjugated antibody against Toxoplasma gondii surface antigens. So these we can see the comma shaped tachyzoites. Now coming to the antibody detection. So acute infection can be established by simultaneous detection of IgG and IgM antibodies in the serum. Okay, so first is the antibody level of more than 1 in 10 could be found as early as 2 to 3 weeks after the infection. Okay. Okay, IgG appears 4 weeks after the infection and peaks at 6 to 8 weeks and then slowly declines to a baseline level. A 4-fold rise in IgG titer is necessary for the diagnosis. So this IgG, but IgG cannot be used in the diagnosis of congenital infection as IgG can cross the placenta. Okay. So IgA detection in the serum could be one of the leading point to the congenital infection. Okay, that is IgA detection either by ELISA or ISAGA methods. Antigen detection can also be done by ELISA. And antigen in the amniotic fluid is also the antigen which is found in the amniotic fluid also points towards congenital infection. The other methods are skin test, animal inoculation and molecular methods and also imaging. Imaging methods, CT and MRI of the brain can be done to demonstrate multiple ring enhancing lesions in the basal ganglia. CSF examination can also be done which includes elevation of intracranial pressure, lymphocytosis and a slight increase in protein concentration. Coming to the treatment. So congenital infection can be treated by oral pyrimethamine 1 mg per kg and sulfadiazine 100 mg per kg with folinic acid for 1 year. And in immunocompromised patients, 1 month pyrimethamine plus sulfa drugs could be given. So in immunocompromised patients, if CD4 count is less than 100, prophylaxis with cotrimoxazole is the drug of choice for encephalitis. Other than that, preventive modalities like proper dealing with the proper consumption of thoroughly cooked meat and hygienic measures while handling the cat litter, proper washing of the hands before consumption of food, and also screening of blood banks or organ donors for antibody to Toxoplasma gondii. So all these measures could be included as preventive measures to prevent Toxoplasma gondii infection. Coming to other opportunistic infections. So these opportunistic infections are the ones which are more commonly seen in patients who are immunocompromised. It could be a HIV infection or diabetes or chronic renal infection or organ transplantation, those who are on chemoprophylaxis, all these are the immunocompromised states wherein opportunistic infections are seen. So which are those? They are Toxoplasma gondii, Isospora Belli, Microsporidium, Entamoeba Histolytica, free-living amoebae, Giardia lamblia, Leishmania species, Cyclospora Caytenensis, Cryptosporidium and Strongyloids tercoralis. Now this is a table which shows the prevalence of the different opportunistic infections in Indian population and Western population. So Cryptosporidium parvum is the most common. So this gets the infection. The Cryptosporidium parvum gets the name because it was first found in the gastric crypts of mouse. It was first reported in 1976. So the mode of infection is fecal-oral route. Man is a single host who is involved in Cryptosporidium parvum infection. So what are the morphological forms? So the oocyst is the morphological form. There are two types. One is thin-walled and thick-walled. Thin-walled oocysts are the ones which reinfect the same host, whereas the thick-walled infect the new host. So this is a oocyst in which we can see 4 sporozoites with a nucleus, rod-shaped nucleus at the posterior end. So this is the life cycle of Cryptosporidium parvum. So here we can see the man is consuming a thick-walled oocyst from the contaminated food or water. Now once inside the intestine, inside the enterocytes, what happens? All these processes take place. That is the asexual cycle. So here we can see that thick-walled oocysts, I have again listed it out here. So first after the ingestion of the oocyst, 4 sporozoites are released from the thick-walled oocyst which develop into trophozoites. They in turn develop into type 1 meron and then type 2 meron. From the type 2 meron, 4 merozoites are released. Now these merozoites undergo many cycles of gametogony, many cycles of sporogony, then they start undergoing gametogony. So what is a gametogony? So these merozoites form micro and macro gamete. Okay, there are 12 microgametes and 1 macrogamete. Fertilization occurs, thick-walled oocyst is formed. Now they undergo sporogony. The sporulated oocysts are passed in the stool. The thin-walled oocysts infect the same host. Okay. Now, what is the mode of infection? Fecal-oral route. Okay. So, animals can also serve as a source of infection. So, the incubation period is about 2 to 14 days. The clinical features are mainly mild diarrhea, which is a self-limiting infection. But only in HIV infected patients, life-threatening diarrhea can occur with severe dehydration. There could be extraintestinal manifestation like respiratory infection, cholecystitis and hepatitis. Coming to the lab diagnosis, stool sample is the most common sample. Other than that, sputum, bronchoalveolar lavage, duodenal washings could be used, biopsy and blood, biopsy sample and blood can also be used. So, if stool is collected, 3 samples should be collected. Concentration method can be used if the Cryptosporidium infection is very low, and by doing the concentration method like Sheether's sugar concentration method, the oocysts can be seen very well. So, this is a picture showing highly refractile oocysts. Modified Zeal-Nielsen method is used. So, you can see the blue background and the pink oocysts. This is immunofluorescent staining method, which is it is more sensitive and specific. So, here you can see the black background and the green fluorescent oocysts. The other method is antigen detection method by ELISA and immunochromatographic test. Histopathology can be done by intestinal biopsy by hematoxylin and eosin staining. Serological methods, immunofluorescent assay and ELISA, specific IgG and IgM ELISA is used. PCR is a definitive method. Treatment is supportive, that is maintaining hydration in the patient who has severe diarrhea. Coming to the next one, Cyclospora Caytenensis. This is a coccidian parasite. So, the morphology of the oocyst is it is about 8 to 10 microns and it is non-refractile. It has 2 sporocysts with 2 sporozoites each. Life cycle is very similar to Cryptosporidium, but when freshly passed in stools, the oocyst is not infective. Sporulation occurs after days or weeks in soil at 22 degree to become infective. So, unlike Cryptosporidium, Cyclospora oocysts are sporulated. They are not infected. They are not infective because they are not sporulated. Okay, they undergo sporulation only after being in the soil for many days or weeks at 22 degrees centigrade. Now coming to Isospora Belli, these are the largest oocysts which are 30 microns into 15 microns. So, you can see they are bigger in size compared to the Cryptosporidium and the Cyclospora. Unsporulated oocysts are passed in the stool. They mature outside to form sporozoites within the oocyst, which later become infective. They also cause mild self-limiting diarrhea. Steatorrhea or fatty stool can also be present. Stool examination can be done with modified ZN technique. We can see the oocysts. Treatment is cotrimoxazole. So, this is the comparative picture of all these. This is the Cryptosporidium oocyst. The next is the Cyclospora, Isospora. So, this is Cyclospora and Isospora. Now this completes the opportunistic protozoa. Now, I have just put the pictures of other opportunistic protozoa which I have already studied. So, this is Entamoeba Histolytica, Leishmania Donovani. These are all the morphological forms of different opportunistic protozoa. This is Giardia lamblia, free-living amoebae. Now, coming to the last one, that is Ballantadium coli. So, this belongs to the phylum Coeliophora, order Trichostomatida. It is the largest protozoal parasite of humans and it lives in the large intestine. So, this is the morphology of the trophozoite. Here you can see the trophozoite which is of the size 28 to 152 micrometers. These are the cilia. This is the macronucleus and the micronucleus. These are the ingested microbes. This is the vacuole. This is the cyst form. Here you can see the cilia here and a cyst wall, a micro and a macronucleus and a contractile vacuole. So, there is only one host in this. Pig is the natural host and the man is the incidental host. The infectious source is a pig or it could be a human carrier. Cyst is the infectious form. Man consumes contaminated food and water, okay, and once he consumes, the trophozoites are released which invade the colon. Okay, now in the large intestine what happens, there is division. So here you can see conjugation helps in the exchange of nuclear material. So you can see that the conjugation is taking place here. Multiplication occurs by transverse binary fission. This is the trophozoite. Encystation occurs. Then the trophozoites and cysts. In this, these are the diagnostic form of the Balantidium coli. So inside this, the multiplication takes place and finally excistation occurs in the small intestine. Often it is asymptomatic, but rarely mucosal ulcers and submucosal abscesses can be seen. The symptoms are diarrhea, frank dysentery, abdominal colic, anorexia, nausea and vomiting. Extraintestinal symptoms like liver abscesses, peritonitis, pleuritis and pneumonia can also be seen. Lab diagnosis is mainly by collecting the stool sample, and the trophozoites and cysts can be seen. Biopsy of the large intestine, scrapings from the internal ulcer. So wet mount and iodine mount can be done. Culture and biopsy can also be done as diagnostic modalities. Now treatment: 500 milligram of tetracycline 4 times a day for 10 days, or metronidazole 750 milligram 3 times a day. Avoidance of consuming contaminated food, prevention of human-pig contact, and treatment of the infected persons by tetracycline and metronidazole. So these are the treatment modalities and prophylaxis.